Good day. So for this lecture, we are going to talk about the evaluation test for secondary hemostasis, and also in the last part, we're going to talk about diseases associated with the platelets. The first test is activated partial thromboplastin time, also called APTT. This test is used to monitor for unfractionated heparin therapy and test for the functions of the factors found in the intrinsic and the common pathways. There are two reagents that are used here. One is platelet phospholipid substitute containing an activator, which can be any of the following: kaolin, selite, silica, or ellagic acid. And the second one is calcium chloride. For the principle, we add the phospholipid activator reagent to citrated platelet for plasma, which is our specimen, and then we incubate it to allow for contact factor activation. After that, we add calcium chloride and we measure the time required for clot formation. Normal and abnormal controls are run together with the patient samples, so for quality control, and the reference range would be around 23 to 35 seconds, but this may also depend on the institution. What does a prolonged APTT mean? Letter A, it can be because of deficiencies in any of the factors found in the intrinsic or common pathways. Factor activity less than 25 to 35% will lead to a prolonged APTT. And this can also be because of the presence of an inhibitor. For example, heparin lupus inhibitor, which is an antibody or another antibody to a specific clotting factor. So we may also experience different problems in the testing. There are sources of errors along the way, for example, improper collection of the sample preparation and maybe problems inherent with the patient. Right, for example, if the blood collection tube is not full, and there is the presence of large clot in the tube. When we say not full, this is not properly filled, underfilled, contamination with other specimens. When the hematocrit is also higher than 55%, this can also lead to a problem. And the presence of lipemia or icterus can also have a problem with the optical method, especially for those that make use of machines to monitor the time. Right. Hemolysis can also lead to shortened APTT, the presence of a small blood clot in the tube, and if plasma contains platelets. Letter B, incorrect reagent preparation and dilution. So this is something to do with the personnel being unable to perform properly. Okay, it can also be because of water impurities. So there may be something in the water that we use, so we have to make use of distilled water. Improper storage, so that can also be a problem. And then letter C, instrumentation problems. Right, for example, temperature, calibration of the machine, light source, and the presence of bubbles in the sample. The next test is prothrombin time, or PT. This is used to screen for the function of factors 7, 10, 5, 2, and 1. So this is for the extrinsic and the common pathways. It is also used for the therapy with vitamin K antagonists like warfarin or coumarin. The reagents used are thromboplastin source, and we remember that thromboplastin is also known as clotting factor number 3 with calcium chloride. For the principle, We add this reagent containing the calcium chloride to saturated platelet poor plasma, and we measure the time required for clot formation. So as we can see, this is much more simple compared to APTT. Just like for APTT, we have to run normal and abnormal controls to make sure that the result is reliable. The reference range is shorter. It takes only about 10 to 14 seconds normally, but again, each institution can establish their own levels. INR means International Normal Ratio. So this is a means of standardizing the report for PT worldwide. This does not depend on thromboplastin reagent or the instrument use, but there is a formula that we can use for this, and it's shown below. INR is the PT of the patient in seconds divided by the PT of the control in seconds raised to the ISI. Right, so INR values are used to monitor the therapy using warfarin or coumarin, and there is no reference range. The therapeutic range is dependent on the condition being treated, and generally this is about 2 to 3. What is this ISI? It means International Sensitivity Index for the reagent. This is a number provided by the manufacturer. We can see this in the sample. I mean in the kit, the testing kit. The most sensitive thromboplastin reagents have a value of about 1.00 based on the WHO standards. Prolonged PTT may indicate deficiencies in the factors that are found in the extrinsic and common pathways. If there is a less than 25 to 30% activity, or warfarin therapy can actually prolong this value. For the sources of error, it's also almost the same for APTT. So there may be a problem with sample collection, pre-analytical, improper preparation, or there may be a problem with the patient. Prolonged PT may be the same for APTT, and falsely short levels would be the presence of small clot in the tube. For another problem, we can experience reagent problems, okay, and this is again very similar to APTT. Right, so the next set of tests are miscellaneous tests. If the PT and the APTT are abnormal, we can perform mixing studies. By doing the mixing studies, we can identify if the abnormality is because of the presence of deficiency in a certain clotting factor or the presence of an inhibitor. This is usually done by mixing the patient sample with normal plasma. So that means the normal plasma will provide the missing clotting factor if there is a missing factor. Right, so this may result in normalization of the parameter being done, maybe PT or PPTT, or it can also be prolonged, remaining prolonged. So if it is prolonged, it may be because of the presence of inhibitor. But if it becomes normal, then that means the problem is with the deficiency of certain clotting factors. Yeah, so that is how we interpret the mixing study. And this mixing study can be done, there should be a pre-tested value before the mixing study, and then immediately after mixing the normal plasma with the patient's specimen, and also about 30 minutes to 2 hours after the test. So it has to be done 2 times. The shortening of the time in the reference range indicates that there is a factor deficiency, as I've told you. If there is no change, so that may indicate the presence of the inhibitor. So what are these inhibitors? It can be because of heparin, lupus inhibitor, factor 8 inhibitor, or factor 9 inhibitor. So fibrinogen level, that's another test, number 2. So this is a way to measure the fibrinogen. What we use here is the thrombin reagent, which is added to the patient's plasma. So again, this is citrated, and thrombin clotting time is obtained by reading against the standard curve, which is inversely proportional to the fibrinogen concentration. Number 3, another test is thrombin time, or TT. This is a qualitative or quantitative test used for the detection of fibrinogen. So the reagent uses thrombin, which is added to the patient's plasma, and again we report this in terms of seconds. In the presence of heparin or degradation products or low fibrinogen level, it will lead to prolongation of the result. There are also factor assays, specific factor assays. If we are suspecting that there is a certain clotting factor that is deficient, we can perform mixing studies. Another test is the 5-molar urea clot solubility test. So this is able to, the clot that is formed can be dissolved by adding 5 molar of urea. A factor 13A stabilized clot will remain intact in this urea solution for at least 24 hours. So that should be the normal. So if there is a deficiency, the clot will be dissolved. So this is fibrin stabilizing factor. Number 6, dilute Russell vapor Binom test. So this is used to detect for lupus inhibitor. Okay, and this is snake venom. This is snake venom that is added to the sample, the patient sample, and this sample will activate factor 10 to become activated factor 10A. So number 7 is activated clotting time. So this is just a normal clotting time, except that we place this in a glass tube. The specimen is placed in a glass tube and determine the time it takes for the clot to form. Okay, we need to use a water bath for this purpose to keep the temperature at 37 degrees Celsius, and this can be performed at different situations. Right, so other than those tests, we can also test for the fibrinolytic system. And here we have 2, the FTPs, fibrin degradation products, and D-dimer test. In the FTP testing, latex particles are coated with an antibody against fibrinogen, and then we mix this with the patient serum. What will happen is that there will be agglutination that will be formed when there is the presence of degradation products. However, this is a non-specific test, and that can lead to abnormal results when the products of degradation are present. For example, in cases of DIC and primary fibrinogenolysis. D-dimer assay, this also mixtures of latex particles coated with antibody, but this time it's against the D-dimer. This is highly specific for fibrin degradation products and does not detect fibrinogen degradation products. So please take note of the difference between those two. Right, abnormal results may indicate that the clot has already been formed and been stabilized by factor 13A or lyse by plasmine. Anticoagulant therapies. Certain patients may need to be treated with anticoagulants, especially people who had history of acute myocardial infarction or heart attack, or people who are prone to acute thrombotic events like those who have arterial or venous thrombosis, deep vein thrombosis if you remember, and then pulmonary embolism, so the presence of blood clots in the circulation, thrombophlebitis. So these patients are given a bolus of heparin, that means a large dose of heparin, which is followed by infusion. So that is through your IV, intravenous therapy. Antithrombin should be present with the levels of about 40 to 60% of normal so that heparin will work. The complex that is formed between antithrombin and heparin will inhibit certain clotting factors that include 12A, activated 12, activated 11, 9, 10, 2, and kallikrein. So it will lead to immediate inhibition of these clotting factors. It will also inhibit the conversion of fibrinogen to fibrin, so there will be no solid clots that will be formed, and platelet aggregation and activation of factor 13. Heparin therapy can be immediately reversed by giving protamine sulfate, so that is the antidote for heparin administration. We have to monitor the activated partial thromboplastin time to make sure that the therapy is working. So the therapeutic range is about 1.5 to 2 times the patient's baseline APTT prior to treatment. So dosage can be adjusted depending on the value that we get. We should also test for the platelet counts or for possibility of heparin-induced thrombocytopenia. We want to prevent that. If this is detected, we have to stop this therapy immediately. Another anticoagulant that we can utilize is warfarin. By the way, warfarin is coumarin is found in rat poison. So this anticoagulant is prescribed on the outpatient basis to prevent extension of existing clots and recurrence of thrombotic events. So this can also be a prophylaxis to patients who have undergone surgery to prevent thrombosis. This is a vitamin K antagonist, and the warfarin inhibits the production of prothrombin group factors like factors 2, 7, 9, and 10. The first one that gets affected is factor 7, so that means it is mainly for extrinsic pathway. Sometimes the therapy with warfarin is included with heparin therapy. So this is to improve the effect of the anticoagulants. So it usually is achieved within 4 to 5 days, and this warfarin can be used up to 6 months or even longer. We have to monitor prothrombin time and INR, and the therapeutic range is about 2 to 3 as we mentioned earlier. If the value is higher, well, so there may be serious bleeding, and vitamin K can be administered to reverse the effect. So vitamin K is the antidote that we can use for warfarin. So we're now going to proceed to the diseases and conditions associated with the platelets. The first group of defects has something to do with adhesion defects. So one of the functions of the platelets is to adhere to the damaged vessels. However, if there is a missing von Willebrand's factor, so this can lead to this condition, von Willebrand's disease. This is important because it's also a carrier for coagulation factor Number 8. Right, so letter B, decreased platelet addition will cause the mucous membrane to bleed in different levels of severity. What we can find in the laboratory are the following: normal platelet, prolonged bleeding time, decreased aggregation response to ristocetin, which is another test, variable APTT, normal PT, decreased von Willebrand's factor, and many others. This is the most common hereditary hemorrhagic disorder and associated with the autosomal dominant inheritance. The second one under this addition problem is the Bernard's-Follier syndrome. So this is characterized by the presence of giant platelets, and these giant platelets lack certain glycoprotein receptors. The addition defect is usually because of faulty binding of the platelet to von Willebrand's factor. So the laboratory test will reveal variable platelet count, anisocytosis of the platelets, prolonged bleeding time, decreased aggregation, response to ristocetin, and normal APTT and PT, normal von Willebrand's factor, okay, so on. Right, so the next set of problems, something to do with aggregation and clot retraction of the platelets. So the first one here is Glanzmann thrombasthenia. So this is hemorrhagic disorder that is seen in populations where consanguinity is prevalent. So that means if there is intermarriage of the related people, relatives. This is especially true for the royalties. Sometimes they get married to people who are related to them, like cousins or something. Right, so the platelets would lack certain receptor that binds with fibrinogen, and therefore if this is missing, the fibrinogen will not be able to bind with the platelets. So this leads to aggregation defects. There is also lacking of thrombastin and actomyosin that can lead to a problem with clot retraction. Right, so laboratory will reveal decreased aggregation response with ATP, epinephrine, collagen, and a normal response to ristocetin. Another problem is storage pool defects. When there is a problem with the storage granules, we know that the storage granules are very important in clotting. So we have here number 1, great platelet syndrome, which is also characterized by large platelets, thrombocytopenia, absence of alpha granules, and patients are prone to lifelong mild bleeding tendencies. The second one is Wiskott-Aldrich syndrome, where the platelets are small, there is thrombocytopenia, there is decrease in the number of granules, alpha granules, and dense bodies. Again, there may be hemorrhage and recurrent infections. Number 3, Hermansky-Pudlak syndrome, characterized by lack of dense body granules. So please take note of what is missing in this storage pool defects. Patient will exhibit oculocutaneous albinism and also prone to hemorrhage. So there are also acquired defects. The taking of drugs like aspirin and NSAIDs, non-steroidal anti-inflammatory drugs, can interfere with cyclooxygenase enzyme. This will prevent the production of thromboxane 8-2, and the problem with aggregation will occur. Letter B, clopidogrel bisulfate and ticlopidine. They are adenosine diphosphate receptor inhibitors, and they can also inhibit platelet aggregation. Letter C, eptifibatide and similar antiplatelet medications can block the receptors in the platelets, preventing aggregation. So most of them affect the aggregation function of the platelets. They will not stick to each other. Myeloproliferative disorders and uremia are also diseases that can cause problems with the platelet function. Immune loss of platelets can be because of different purpura, neonatal purpura, post-transfusion purpura, immune and the idiopathic thrombocytopenic purpura, and heparin-induced thrombocytopenia. The fourth reason is splenic sequestration. So hypersplenism may result in more than 90%, about 90% of the platelets being removed. There will be increased destruction and damage of normal platelets, and splenomegaly may occur because of leukemia, lymphoma, Gaucher's disease, and storage diseases, cirrhosis of the liver, and even sarcoidosis. Hereditary conditions like Mehiglin anomaly, Werner-Solier syndrome, and Wiskott-Aldrich syndrome can also lead to hypersplenism. Right, so falsely low counts when there is platelet satelitosis. So there's actually normal platelets, but they are attached to neutrophils when exposed to EDTA. So to correct this, we can redraw the specimen using citrate. Multiply the obtained platelet count by 1.1 to correct for the dilution factor. ETA-dependent platelet agglutinins may be present, and platelets can adhere to uh, each other when exposed to this anticoagulant. Correction of the problem is the same for platelet satelitosis, so there will be multiplication of the platelet count by 1.1 to correct for dilution. So that is the last slide for this presentation. Thank you for watching.